Hi, I'm Dr. Harold Burstein from Dana-Farber Cancer Institute, and thank you for joining us for a session and interactive patient case discussion on the role of CDK4/6 inhibitors in advanced breast cancer. This is a whole new class of drugs that we are rapidly coming to speed on. We've seen several FDA approvals and reports from major trials in the metastatic setting come forward in the past couple of years, and it's really been an exciting space to see a whole new class of targeted therapy emerge in breast cancer, which hasn't had a new class of targeted therapies really since the anti-HER2 drugs came along about 15 years ago. So I'm delighted to be joined today for this case discussion by Professor Kim Blackwell. She is professor of medicine at Duke University and an ambassador for science at Duke and leads a variety of their innovation programs and things. Kim, thank you for being here today.
Sure, thanks for having me, Al.
So you brought in a case that I think is pretty good as an example of a first-line discussion. So why don't you run through the case details and we'll talk about what you might think about with this patient.
Yeah, so this case is of a 57-year-old. She's actually thinking about retiring school teacher who had breast cancer at age 50, so about 7 years ago. She actually was node negative at the time and basically went on to receive initially tamoxifen because of questions around menopausal
perimenopausal
age 50. And then we switched her after about 2 years. She came in, hadn't had menses for a year, had postmenopausal levels of FSH and estradiol. We ended up putting her on an anastrozole.
Got it.
She finished her total course of 5 years of anti-estrogen or endocrine therapy, and she did well on it.
Yeah.
And then she kind of got, as is always a stressful time for our patients, she kind of got discharged from the breast cancer clinic, and we said, good luck, you're probably cured, we'll see you back if you need us, but we hope we don't see you again. And I got a call probably about a couple weeks ago that she had developed a cough, and you know, we all get these calls, right? The PCP calls me and says she has an abnormal chest x-ray, doesn't look like pneumonia, and the radiologist says it's cancer. So she gets sent to me, we scan her, stage her, biopsy her, and she has recurrent ER positive, PR positive, HER2 non-overexpressing breast cancer that's metastasized. Interestingly enough, she has a couple spots in the bone, but the majority of her metastases have returned in the lung. So, you know, kind of a little bit more aggressive picture than cancer that's only recurred in the bone, and a little symptomatic. And so I think what we're going to discuss is really what you and I would do with this case.
So just to recap, a 57-year-old, now postmenopausal, T2N0, and did you get an oncotype DX or anything like that? No chemotherapy at the initial time?
I don't remember if we actually got an oncotype,
but you did get chemo.
But I certainly would have done it today.
Right.
Let's just assume it was a low oncotype.
So she gets 5 years of adjuvant endocrine therapy, a couple years of tamoxifen, a couple years of an AI, wraps up 5 years of treatment. Now, 2+ years later, she's back with visceral metastasis, mildly symptomatic with a cough, and you've rebiopsied it, and it was ER and PR positive and HER2 negative. Quick question, did you get any genomic sequencing? Did she have one of those ESR mutations or things like that?
No, I'm not using those routinely for de novo recurrent disease, but I mean, I think it's a reasonable consideration.
Yeah, we have a platform to do a lot of research-based testing for that still, and you know, in general, it doesn't turn up a lot in these ER-positive cases. They tend to have relatively uncommon mutations. But this ESR1 thing has kind of been of interest to me as a potential predictor for resistance to AI treatment.
Yeah, and you know, the hard part about this case is it's that 2 years of disease-free interval, right?
Right, because it's a little bit, but it's not a lot.
Correct. So it's not like we stopped her AI and it came rip-roaring back 3 months after we stopped it, which would really, to me, indicate that she still remains AI sensitive.
Right.
And she's not 5 years out, so my assumption is, who knows? It's that 2 year that is challenging for me. Even in the HER2 world, it's that they didn't recur really early after stopping drug, and they didn't recur really late. That 2 years a challenging time point for recurrence.
It's a good point, and you know, in some cancers like ovarian cancer, there's a pretty robust literature on, you know, 1 year of platinum interval means a lot more than 6 months or something. But in breast cancer, it's never been explored so rigorously.
I don't think we've really looked at it. I mean, we're starting to see some of that data. You know, at this year's ESMO, there was some data regarding disease-free interval in the setting of the Monarch 3 study, but it's data we haven't followed, and I don't know if it's just because we're not collecting the data in the way we need to look at it in a large-scale series.
Yeah. So let me start by asking, I mean, does this patient need chemotherapy up front? So, I mean, I think a lot of people in the community would think lung mets, has had endocrine therapy, mildly symptomatic, maybe we should just start some chemo, especially in someone who might have been chemo naive.
Yeah, and that's why, I think this case is interesting because she is symptomatic. Like she went to the doctor because of a persistent cough and really just not so much hypoxia or dyspnea on exertion, but just something's wrong.
Yeah.
So I would qualify her as mildly symptomatic. And I could see where chemo at least needs to cross someone's brain in thinking about her treatment
Not
options.
the blood-brain barrier. We're just talking about thinking about chemotherapy.
Yeah, I think everyone who's taking care of breast cancer patients should say, how quickly do I need the treatment to work?
Right.
How sick is the cancer making the patient, and how sick is the treatment going to make them? I mean, that's really the three critical questions, right? So in this case, does she need it to work in the next 2 weeks? No. That's a visceral crisis kind of thing. Would it be nice if it kicks in the next 8 weeks? Sure. Can she make it 8 weeks and allow it to kick in? Sure. So we don't need a super rapid response.
Yep.
And, the thing we're here to talk about are these CDK inhibitors. And there's been some really nice, I think, data that really suggests that the CDK inhibitors, unlike their partner endocrine therapy, kick in really quickly. Mm-hmm. So at least I was always taught, and what I tell my patients is, it's going to take a month for the aromatase inhibitor or the fulvestrant to kick in. So at least pharmacokinetically we know that. Biologically it probably takes 4 weeks to see a anti-proliferative effect. And there have been 2 studies in the CDK world, both in the preoperative setting. So one was presented in the past year where they initiated CDK inhibitor with endocrine therapy for preoperative therapy and then biopsied the tumor 2 weeks later, and they saw a 90-something% reduction with the CDK in Ki67.
Right, so you're seeing an anti-proliferative effect emerge almost immediately with down exposure. So let me just go back, though, to the basic question of chemo versus hormone therapy. What I think I'm hearing you say is that obviously you're looking for a reason why do they perhaps urgently need chemo or not, but your growing suspicion is that the activity of the CDK4/6 inhibitors might actually be shifting that dialogue, making us less likely to pull the chemotherapy trigger first rather than start some endocrine therapy. I can tell you that the guidelines all say use endocrine therapy first, but we know from practice pattern data that at least half the patients like this would start with chemotherapy in the real world.
Yeah, so the answer is do not use chemotherapy in this patient. At least that's my opinion, and that would be consistent with the guidelines. But some of the data that's emerging really suggests that unlike traditional endocrine therapy as a single agent, when you add the CDK inhibitor, you see this fairly rapid onset decrease in Ki67, almost identical to what you would expect with chemotherapy. So that's actually fueled less use even in my practice, even in people that I really need to see a response in the next 2, 3, 4 weeks of biting the bullet and putting them on endocrine therapy plus a CDK inhibitor.
So these studies are old, but and undoubtedly subject to a selection bias because they were randomized trials of chemo versus endocrine therapy. But the interesting thing is there never was a study that showed a major benefit for chemotherapy up front, and in terms of response or obviously survival. So before we launch into our discussion of endocrine treatments for this patient, because it sounds like you're going to not pursue the chemotherapy as first-line treatment, tell me what her experience had been on the adjuvant endocrine treatment. How did she tolerate it? How compliant was she with therapy?
So she's kind of a great patient. I find that
all your patients are great patients.
Yeah, all of them, but and I'm being very stereotypical, but teachers and nurses, I think in general, all patients understand the importance of their treatment, but I think in general she's a teacher, so she wants her kids to do their homework. She's going to do her homework and take the things. So, and she's definitely one of these patients that says, first she's in shock because her cancer's come back, and I've told her for 5 years. Then I kicked her out of the clinic. Right. Basically, you have a highly curable breast cancer. I didn't say cured, but I said highly curable. And so she's kind of in a just tell me what I need to do mode.
Right, very matter of fact at this point. She's handling it reasonably well.
Correct.
And in the past, the hormone treatments weren't a problem in the sense of debilitating side effects or things.
Yeah.
Okay, so we're 2 years out from an AI. We're thinking about hormonal treatments for recurrent disease. And so what did you recommend for her?
So I put her on a combination of letrozole and ribociclib.
Okay.
So that's what I refer to as Mona Lisa 2
Mona
or
Lisa
Mona
2.
2.
Mona, okay.
So, all of these drugs become cumbersome, i.e. with the long words. So that's my Mona 2 regimen of an AI and ribociclib. So, and I think, she certainly meets, in my mind, the criteria of still having endocrine-sensitive breast cancer that's recurred, minimally symptomatic. And I think we'll get to this, but across all 3 first-line studies with an AI now, including abemaciclib and palbociclib, bottom line is that they all have shown a significant improvement in progression-free survival, and so that's what I put her on.
So you're referring to a series of trials that have come forward this past year or two, really, exactly as you said, 3 large randomized trials, all in first-line therapy, all with an AI plus or minus a CDK4/6 inhibitor. And the 3 products that have been studied heavily are palbociclib in the Paloma 3 trial, ribociclib in Mona Lisa 2, and abemaciclib in the series called Monarch from that manufacturer. And what's a couple of interesting things to me about those trials. One is that the control arm in those studies had almost exactly the same duration of treatment. It was like 14.5 or 14.7 months in each one of those 3 studies with single agent AI, which is an incredible consistent finding now in first-line therapy for median PFS for ER-positive breast cancer.
Well, what's even more impressive is the hazard ratio for adding the CDK inhibitor is identical
to within a hundredth of a decimal point.
I mean, to me, to have 2 studies that kind of match up and show benefit of an agent is pretty impressive, right?
Yeah.
We very, very rarely see that, right?
Yeah.
We debate adding platinum, and the benefit oscillates in the early stage setting around 1% benefit to 4% benefit. But to have a hazard ratio with a similar class of drugs identical across 3 large phase 3 studies, to me, really speaks to the power that these drugs are adding something.
Yeah, no, I agree. There's an interesting discussion right now about reproducibility in clinical medicine.
Yeah.
And this is clearly an example where there is a high degree of reproducibility. And the hazard ratios, exactly as you said, 0.55, 0.57, 0.54, I mean, truly almost overlapping. I went to the New England Journal of Medicine articles on palbociclib and ribociclib, and you can cut out the Kaplan-Meier figures and hold them up to the light, and they are truly superimposable.
I think you need a better hobby. Hal.
Well, we all need something to keep us busy on the weekends.
Yeah.
So you selected ribociclib. Now, one of the interesting things about ribociclib is that it's not continuously dosed, and you also need some baseline testing that might be a little different from some of the others. Tell us about that.
Yeah, so the data that emerged out of Mona 2 and Paloma 2 is the palbociclib equivalent. So they're both looking at the use of a CDK inhibitor in combination with first-line aromatase inhibitor. But the data in Mona 2 showed that I think it was like 4 or 5 patients had some QTc prolongation
with ribociclib.
With ribociclib, and so therefore, as part of the package insert and as part of appropriate use of the drug, it is recommended that you get a baseline EKG, an EKG at 2 weeks, and then at the start of each cycle, so 4/8. And most people have figured out what to do. There are some programs available where they will actually. They have like a wrist EKG monitor of some sort and home EKG monitoring. But you're seeing those patients for labs anyway. As you mentioned, it's not a continuous dosing. All patients that are initiated on CDK inhibitor, whether it be palbociclib or ribociclib, are needing counts done. At least I'm checking them per the package label at day 14 and then at the beginning of cycle number 2. So they're in the office anyway. A lot of these patients, including the patient we're discussing, has some bone mets, so we have her on a bone health agent, which requires a monthly labs. And so, although we've kind of made a big deal out of it, even I was kind of like, kind of just another thing to have to remember. I mean, I can barely remember to get echoes in people on Herceptin or trastuzumab, and just one more thing to worry about. But it really just has not been that big of issue. When you order the labs, you order the EKG, and I've not had a lot of complaining. The other thing that we saw is that there were some elevations in liver enzymes on the ribo study that have not been appreciated, at least to any extent, with the palbo studies and now the abemaciclib studies. And so it is recommended that routine liver function test monitoring. So those are the two things that if you're going to prescribe ribo, you really need to be aware of those, because it is different than probably the practice style with palbo.
So, so both palbociclib and ribociclib are dosed 3 weeks on, 1 week off, and abemaciclib, by contrast, being continuously dosed. Say a little bit about the contrasting side effects of ribociclib, palbociclib, and abemaciclib.
Yeah, well, the most predominant toxicity of palbociclib and ribociclib is neutropenia. And it's this very interesting grade 3 neutropenia, meaning, or grade 2, grade 3, so you really see a consistent absolute neutrophil count of less than 1,000 at day 14, day 21, which is the end of the dosing cycle, and yet minimal to no febrile neutropenia. So, there's a lot of hypotheses about this. It's definitely a different neutropenia than what you see with chemotherapy. At least that's my sense, in having prescribed these drugs now for 2 or 3 years. And people have to learn to kind of be comfortable with that. I mean, we're so used to getting the call that the ANC is 500, and then everyone has a freak out. Oh, we got to readjust the schedule, and are we holding the drug? Of course, with chemo. With these drugs, you push through in the absence of fever. And, the guidelines, once you get familiar with how you dose adjust both palbo and ribo, I encourage everyone, whichever drug you're going to use, get the dose adjustment printout from the internet, post it at your workstation, because it is pretty straightforward, but you kind of need to teach yourself how to do it.
Sure.
So that's the one thing that all people need to worry about if they're prescribing these CDK inhibitors, is you got to follow the counts. Patients need to be aware, and we see the same thing with drugs like capecitabine, right? People think they're taking a pill and they don't have to worry about fevers and the various sundry other things. So you kind of have to caution patients, listen, we still need to check your counts. Even though this is a pill, it's an oral medication, we need to keep a close eye on this. Abema is a little different. So the main toxicity seen with abemaciclib is, we'll just call it Abema. Abema is that, at least in the recent studies, about 10% of people develop grade 3, 4 diarrhea.
Right, so lower GI toxicity.
Right, so not a lot of grade 4 diarrhea, but there's that 1 out of 10 patients that will get into trouble, with a diarrhea that requires some form of intervention. Mm-hmm. And a good chunk of those patients, about 1 out of 3, actually had lower abdominal discomfort. That's straight from the Monarch 3 study that was just presented at this year's European Cancer Congress. So different toxicity, not a lot of neutropenia with Abema. You can see it, but it's in the single-digit range, and 0 febrile neutropenia with Abema.
So just to contrast, ribociclib and palbociclib, a little discontinuous dosing, 3 weeks on, 1 week off. Neutropenia, less diarrhea. Abemaciclib, more diarrhea, less neutropenia, continuously dosed. And there's a funny thing about the creatinine for abemaciclib also, right?
Yeah, right. So you have to routinely monitor the creatinine. And I'm not quite certain if it's a direct, I think some people think it's a direct drug effect, but some people also think it's a pre-renal kind of phenomenon.
My understanding is it's not actually in renal injury, but it is mostly a laboratory artifact. But
correct.
You get these funny creatinines back that are confusing.
Yeah. I will say with Abema, so one of the things I'm thinking about just practically, because I'm going to make an assumption that Abema will also become commercially available given the hazard ratio similar to the already 2 approved drugs, is that I was thinking continuous dosing was going to be great, right? Because 3 weeks on, 1 week off, it gets confusing for patients, and maybe we'll talk about this in a few minutes, but continuous dosing is more consistent with what we do with many, right, if not the majority of oral medications. In Monarch 3, though, there were a fair amount of dose adjustments. So I think if you're going to, when it becomes commercially available, it's not, you can't have it in your head, oh, I'm just going to send this patient home and see them back at 28 days. They still require monitoring. I mean, I'm going to view it kind of like almost like an everolimus kind of drug where you really need to see the patient back at least in my practice, 2 to 3 weeks into it. And even if you're not going to be fine, we don't know what the package insert's going to look like but it's not, the continuous dosing isn't going to allow you just to send the patient home.
Doesn't
with
solve
the
the monitoring and some of the other issues.
So I think in terms of patient hassle, that's the only way I know how to scientifically summarize patient hassle.
The Blackwell patient hassle scale.
Well, and then we have a physician hassle scale, but we'll talk about that later. Is basically, I think patients and the requirements on patients, at least in terms of time, laboratory monitoring, are going to be about the same for all three of these drugs.
It's increasingly getting hard to think like who would be a candidate for one of these products as opposed to the others. So how did this patient do when you started therapy?
Yeah, so she's 8 weeks into it.
Okay, 2 months.
Her scans are stable, so her cough's a little bit better. I'd like to say it went away completely. I'm a scanner, so I scan people in 8 weeks. Some people would scan this patient at 12 weeks, but at least at 8 weeks she has stable to maybe slightly improved, and clinically she's better.
And tumor markers or anything like that changing
I
or anything?
don't use tumor markers, but I'm sure if we check them, I don't use them because I like bidimensional measurements, and we could do a whole nother CME activity on how we monitor metastatic disease.
But you're satisfied at 2 months that she's on track and you're...
She feels better, and sometimes that's better than any CT scan. So, and she's tolerating the treatment extremely well.
Let me just throw in a couple of wrinkles in this case and see how it might have affected your thinking about it. So if she'd had minimal disease, so an incidentally found rib lesion or an isolated pulmonary nodule, would you have felt the need to add the CDK4/6 inhibitor to the endocrine therapy?
Yes, I'm an all doser, all comer CDK inhibitor, and in part because we talked about this a little bit earlier, but I view a hazard ratio or 45%, the flip of the hazard ratio, 45% improvement in progression-free survival is meaningful. And some people would say the patient with the isolated MET, well, they have good metastatic breast cancer. That drives me crazy. I mean, the fact that it was smart enough to come back 7 years later tells me it's smart enough to overcome endocrine therapy again. So in general, I offer this to all of my patients facing ER positive, and I know there's a lot of controversy around this, but I don't think that I know how to select for the good isolated MET because we picked it up late and had been there for a while, or the bad isolated MET where there's 1 or 2 bone METs, at that 2-year period, that patient wouldn't drive obtain additional benefit from adding a CDK inhibitor.
Well, it's an interesting discussion. I mean, there aren't any data, but since most of these patients in American practice right now would get a CDK4/6 inhibitor as first or second line therapy, one of the questions is there a rational way to use these, or are there some patients who could, on the Blackwell patient hassle factor, sort of do without for the time being, and then initiate these drugs later in the course of their disease? And I'm with you. I don't think we have any tools aside from sort of clinical hunches to inform that in any way. Some patients obviously like taking less in the way of treatment at any given moment in time, and for them, I'm still pretty comfortable using single-agent endocrine therapy alone. But increasingly, especially for a symptomatic patient like this, I too would favor incorporating the CDK4/6 inhibitor.
I think it needs to be a dialogue. I mean,
Yes.
I don't want you to get the impression I'm forcing people to swallow the CDK inhibitors, but I think in general, I'm somewhat informed from the history of having effective drugs, and these are effective drugs. And I was a little, in the early trastuzumab days, which you remember extremely well. I mean, we did learn a lesson with trastuzumab. Now, granted, that drug had a survival benefit in the first-line metastatic, but there was a survival detriment if you held off and started it in the second-line setting. And yes, none of the CDK inhibitors have bestowed a survival benefit.
So far, we haven't seen that signal. It may yet emerge.
Correct. But I just, again, in the absence
Is that
of
important to you?
clinical
Do you think
trial,
we need to see a survival signal here to make you enthusiastic about this class of drugs?
I think these patients do well, as you know, for months to years after their initial diagnosis of recurrent or stage 4 breast cancer. And I think that we're starting with longer follow-up. I was very intrigued with the MONA-2 update, because if you look at that study, in the US population, there is a survival benefit for adding ribo. Now, that's dangerous. You're gonna like
you mean the subset of patients treated in the US?
Slap my hand for looking at a subset survival analysis with inadequate follow-up. But if we saw a survival benefit, that would be amazing. And it might drive my use of one CDK inhibitor over the other, right? So to see if we, I'm not going to name names, but if one of these first-line phase 3 studies demonstrated survival benefit and the other two did not, that would be very important to me.
That's an interesting point. I mean, the PFS curves are so similar. It would be surprising to me if one of the products ended up with a survival benefit while the others did not, because in all other respects they seem very, very similar. But I'd like to see a survival benefit. I mean, we shifted PFS from that 14-month benchmark really to 25, 26 months, and it's almost a year in those studies. And you like to imagine that that extra year's head start does begin to translate into a survival benefit for patients.
I think it's going to boil down. If we see it, it's going to be a reflection of tolerability, honestly. So
what have you told this patient about tolerability and if you had to adjust the dosing in her based on neutropenia or anything?
So we haven't had to adjust the dose in her, although I'm predicting that within the next 2 cycles we probably will, because she's one of these patients that hovers, cycle 1, day 14.
1100.
Yeah, 1100, and then she comes back at cycle 2, day 1, and she's at 1200, and I just continue to check the day 14, cycle 2, because I've had a couple of people do really well on cycle 1, and then cycle 2, they come in at day 14, and their ANC is 300. So,
kind of bottom out
but
there.
she's not at 300. She's oscillating between my 800 and 1200, and we'll just have to see how it goes.
Yeah, I mean, that's in broad strokes similar to my experience. Patients who've had a lot of chemo in the past, and not surprisingly, patients with more guarded performance status, their counts get lower quicker, has been my experience.
Really? You're better than I am, because I'm not good at predicting the frail kind of maybe more advanced age person who I thought, oh, this is going to be a nightmare to get through. Haven't had to adjust their doses. And then the kind of hardier, younger patients. So I'm not good at predicting who's going to run into trouble or not. And I'm certainly not starting people. I get asked a lot for second opinions about I see a trend where people are trying to guess and then they're starting at a lower dose. And I wouldn't advise. I think you should start at the approved dose and then dose adjust based on the side effects.
Great. Well, thank you. I hope she does well. You'll have to give us an update in a couple of months and see where things are at. So a great discussion. So we've covered the major studies and these 3 drugs, which we expect will soon all be commercially available. Right now, palbociclib and ribociclib on the market. And what's been exciting for me to see, as I said, is this whole new class of targeted therapies. We didn't get much into the mechanism of action, but these are drugs that probably will have activity in other tumor types. So once again, breast cancer leading the way for a new targeted therapy. Thank you for joining us today. I'm Hal Burstein from Dana-Farber Cancer Institute, and I've been speaking with Kim Blackwell from Duke University Cancer Center. This has been a patient-based interactive discussion looking at CDK4/6 inhibitors and their role in ER-positive metastatic breast cancer. Thank you again.